Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day. We want you, yes, you, to join the Behind the Knife team as a surgical education fellow. We're looking for enterprising surgical residents to take the bull by the horns and build something new and exciting. Fellows will benefit from ample support from the Behind the Knife team, including the use of our digital education platform and access to all of our resources like illustrators, video editing, AI tools, social media, and more. Get your name out there and build your CV by being part of the #1 surgery education platform in the world. We're offering a 2-year fellowship starting in July 2026 and ending in June 2028. Only residents beginning their 2-year academic development time will be considered. Check out the show notes for more information, including the application link. All applications are due on April 20th. Again, all applications are due by April 20th. Now, get out there and dominate the day.
Welcome back to our Behind the Knife listeners. I'm welcoming back the colorectal oncology surgery team, including myself, Janet Alvarez, my colleagues, Wini Zambare, Phil Bauer, and Dr. J. Joshua Smith. We have an esteemed panel of guests joining us today. First, we have Dr. Michael D'Angelica. He is part of the hepatopancreaticobiliary surgery service in Memorial Sloan Kettering Cancer Center. He is the Enid A. Haupt Chair in Surgery, as well as the Vice Chair of Education. We also have Dr. Cathy Eng, who is part of Vanderbilt Ingram Cancer Center. She is the David H. Johnson Endowed Chair in Surgical and Medical Oncology, Professor of Medicine of Hematology and Oncology, the VICC Associate Director for Strategic Relations and Research Partnerships, as well as the Executive Director of the Young Adult Cancers Program. Lastly, we have Dr. Nina Sanford. She is part of the Radiation Oncology Service at UT Southwestern Medical Center, the Chief of Gastrointestinal Radiation Oncology Service, as well as an Associate Professor. Thank you so much for joining us today. Our topic of discussion is management of metastatic colorectal cancer. First, let me provide some context prior to our discussion. As we've mentioned in prior podcasts, colorectal cancer is the third most common type of cancer diagnosed worldwide, and now the leading cause of death for patients under the age of 50. The American Cancer Society estimates about 158,000 new cases of colorectal cancer in this year. The incidence of early onset colorectal cancer has been increasing among younger adults, as we've also discussed on a prior podcast. Unfortunately, an estimated 20% of patients at presentation will be diagnosed with metastatic colorectal cancer. The 5-year relative overall survival for patients with metastatic colorectal cancer is estimated to be 15 to 16%, with most experiencing a survival of 24 to 36 months. The most frequent sites of metastases are the lymph nodes, liver, lung, and peritoneum. Currently, up to a third of patients with metastatic colorectal cancer are limited to disease in the liver, which may be cured with systemic treatments and local regional surgical removal of metastases. Now, first-line treatment is determined by various factors, including a patient's molecular profile, patient characteristics such as comorbidities, age, tumor burden, and as well as metastatic sites and their potential for resection.
All right, thanks, Janet. Let's get to our clinical case. In the ED, we meet a 60-year-old female. She's presenting with symptoms of constipation, abdominal pain, and bright red blood per rectum. She endorses unintentional weight loss in the last year. On colonoscopy, she is found to have a rectal mass 3 to 5 centimeters from the anal verge, consistent with invasive rectal adenocarcinoma. On CT imaging, she is found to have lesions in the liver suspicious for metastatic foci. Dr. Eng, would you care to share your perspective on how systemic chemotherapy could be utilized for this patient?
Definitely. Thank you for asking me. The era of chemotherapy really began with 5-FU, followed by the addition of irinotecan, which is a topoisomerase I inhibitor, and oxaliplatin, a third-generation platinum agent, which is involved in DNA replication and transcription, as part of the 5-FU-based combined therapies, which are FOLFOX or CAPOX if you combine it with capecitabine and FOLFIRI. Whenever I see a patient with a primary tumor intact, like this patient as mentioned here, we need to confirm that there's no impending obstruction and we have clearance to proceed with systemic chemotherapy. So this is really where this is a multidisciplinary effort with our surgical colleagues and our radiation colleagues as well. We will then attempt to individualize care based upon the patient's performance status and evaluate other comorbidities. All patients, regardless of stage, are recommended to undergo testing for microsatellite instability, also known as MSI high status. And for patients with metastatic disease, we also order next-generation sequencing, also known as NGS, all of which will be discussed in the following section. For the majority of patients, combined chemotherapy is a standard of care if a patient is believed to be healthy enough to tolerate treatment. First-line therapy consists of either oxaliplatin-based treatment, once again FOLFOX or CAPOX, or irinotecan-based treatment, FOLFIRI, or in a very healthy individual in which you want to reduce the tumor burden as much as possible, there is the consideration of FOLFOXIRI, which is oxaliplatin, irinotecan, and 5-FU in one combination. Initiation of systemic chemotherapy is typically recommended before any consideration of surgical management of either the primary tumor or the liver lesions, especially if there is bilobar liver metastasis. Now, regarding first-line chemotherapy, as mentioned earlier, we like to look at molecular subtypes, and a major advancement came with the addition of so-called targeted therapies. In this current age of precision medicine, the molecular profile of a patient's metastatic colorectal cancer tumor is important to determine their response and sequence of therapy to targeted agents. Patients benefit from their tumor tissue being tested for MMR or MSI status, RAS, BRAF, V600E mutation, and HER2 amplifications or mutations. It is important to note the molecular heterogeneity of this disease can influence a patient's response to targeted therapies despite having an actionable gene alteration, and survival may be impacted by the molecular subtype and predicts prognosis, as well as therapies that may or may not be effective. An estimated 5% of patients have what's called MSI high or MMR deficient tumor types and would be candidates for immune checkpoint inhibition with PD-L1 or PD-1 blockade, with nivolumab and the CTLA-4 inhibitor ipilimumab, or single-agent pembrolizumab. Now, studies that have demonstrated this are from Keynote 177, which looked at pembrolizumab alone, and then Checkmate 8HW, which looked at nivolumab and ipilimumab in combination versus chemotherapy, as well as versus nivolumab alone. And that was all in favor of the doublet for that patient population. Anti-EGFR therapy or anti-epidermal growth factor receptor monoclonal antibodies, cetuximab and panitumumab, are also effective in patients specifically that are RAS wild type, meaning KRAS, NRAS, and BRAF V600E wild type tumors. They're commonly combined with other chemotherapy regimens to optimize outcomes. And interestingly enough, tumor location is associated with response to EGFR inhibitors, with guidelines recommending their use in left-sided tumors. In summary, it is not recommended in patients with right-sided tumors or treatment-naive tumors to receive anti-EGFR therapy, as well as in the setting of having a RAS mutant tumor type. There's recent data that actually has demonstrated there's improved survival, also in combination with FOLFOXIRI and anti-EGFR therapy. However, the PFS and the response rate were very comparable between the two arms, so that literature is a bit more controversial and just recently came out. In regards to the left-sided tumors benefiting from anti-EGFR therapy, that is based upon the phase 3 paradigm trial. Now, there is some more really interesting new literature which demonstrates that we know that RAS mutations occur in greater than 40% of metastatic colorectal cancer cases and are associated with a worse prognosis, as mentioned, and resistance to anti-EGFR therapies. But there's been some new literature supporting the role of KRAS G12C inhibitors, such as sotorasib and adagrasib, and they've been tested as monotherapy and in combination, and are currently approved in the refractory setting. There are ongoing trials that are looking at the combination with chemotherapy, such as Codebreak 301, which is sotorasib in the frontline setting, and then Crystal 10, which is looking at adagrasib in the second-line setting. Keeping in mind that KRAS G12C mutation is very rare. It's only 2% of our patient population. And then one other thing I'd like to highlight, obviously for those patients that have a RAS mutation, they aren't candidates for anti-EGFR therapy. And for patients that are MSI stable, they cannot receive immunotherapy. So in this case, we commonly provide anti-angiogenic agents, which are currently approved for in combination with chemotherapy. And these agents bind to the vascular endothelial growth factor family, or VEGF family. Bevacizumab, as many of you may know it, basically blocks anti-VEGF-A and can be administered in combination with first-line treatment and is often given in second-line therapy as well, even after following progression of disease. It's really important to note that bevacizumab can lead to bleeding, arterial thrombosis, potential risk of bowel perforation, and delayed wound healing. So we like to discontinue it at least 3 to 6 weeks before a surgical procedure. And I think that's really important to just bring this up since Mike is also on this conversation, and I'd love to hear his thoughts about, what his thoughts about duration of the chemotherapy should be, and when does he like to hold the bevacizumab if it's been provided.
Sure, I can comment on that. If you're ever going to proceed with liver surgery in the context of systemic therapy, which is very, very common, that patients are on systemic therapy prior to considering liver surgery for resectable metastases. For bevacizumab, we like to hold it for about 6 weeks before surgery. That's 2 half-lives, so in general, that will have minimal effect. And studies have shown that surgery is very safe if you're in that approximate window. In systemic chemotherapy, there's a wide variety of practices. Some people will wait over a month before stopping chemotherapy. We will wait 2 or 3 weeks sometimes, as long as there's no problems with neutropenia or other counts. So I think at least 2 or 3 weeks off of chemotherapy. Some people prefer more. I think the more important thing is the duration of chemotherapy prior to surgery. If possible, the less is better in terms of safety of liver surgery, if it's possible. Of course, sometimes you're trying to maximize response before considering liver surgery.
Thanks so much.
Excellent discussion. Let's bring it back to our case. So in our clinical case, further molecular testing does become available. We find out that our patient is KRAS wild type, BRAF V600E mutated, and HER2 negative. Dr. Eng, which therapies would be available based on her molecular profile?
Yeah, this is a great question and very timely because we have some new developments. BRAF V600E mutation, it's very specific to the V600E mutation. It historically, in MSI stable patient population, confers a worse prognosis and often is less responsive to chemotherapy. It's about 9% of our patient population. And these patients commonly present, they're women with right-sided tumors and mucinous or poorly differentiated histologies. They often frequently metastasize to the peritoneum. And previously, despite the best therapy possible, including FOLFOXIRI, the median survival was only 12 to 14 months with systemic chemotherapy. But we now have some new data regarding combination of cetuximab and encorafenib, which is a BRAF inhibitor, specifically, once again, the V600E tumor type. The original phase 3 Beacon trial randomized patients who had had at least one prior regimen to encorafenib binimetinib, which was a MEK inhibitor, and cetuximab, or encorafenib plus cetuximab, versus a control group of systemic chemotherapy of either irinotecan and cetux or FOLFIRI. And what we found after prolonged follow-up is actually the doublet of encorafenib and cetuximab was superior in regards to the control arm, but also less toxic than the triplet arm, including binimetinib, which had toxicities including diarrhea. So as a result, encorafenib and cetuximab became approved in the refractory setting. But we've had recent data from within the past year from a trial called Breakwater, which was specifically conducted. It was a phase 3 trial specifically conducted in the BRAF V600E mutant tumor type treatment naive, and patients were randomized to FOLFOX plus encorafenib and cetuximab, and there were 3 arms originally, versus chemotherapy or versus encorafenib cetuximab alone. That arm eventually was discontinued, and what we learned is basically the median overall survival when you add FOLFOX to encorafenib and cetuximab has now improved to 30.3 months, which is a big breakthrough versus 12 to 14 months for standard chemotherapy. So in this case, this patient, newly diagnosed, should receive FOLFOX plus encorafenib cetuximab. And then actually just last week, the approval of FOLFIRI was just approved as well because they fulfilled the primary response rate of 64% versus standard treatment. Other molecular markers, HER2 amplification is observed in 2 to 4% of all metastatic colorectal carcinoma patients. Patients with treatment refractory disease have shown to benefit from HER2 targeted therapy, which includes tucatinib and trastuzumab, which was the original Mountaineer trial. And there's an ongoing Mountaineer 3 trial for newly diagnosed HER2 amplified patients. And I really want to mention amplification is extremely important, 3+ by IHC or 2+ confirmed by FISH.
Okay, let's say that our patient unfortunately was treated locally, did not receive cetuximab, but was treated with CAPOX, and primary tumor and metastases don't seem to have responded very well. What additional options would be available to her in the second and even third line treatments?
Sure. So in this patient with the BRAF V600E mutant tumor type, we would then do the standard of care, which would be encorafenib and cetuximab, and that would be the standard of care in the second line setting. Now, if she did not have the BRAF V600E mutation, for second line therapy, as mentioned earlier, sometimes we continue on the treatment with anti-VEGF therapy. But once again, we have to evaluate the molecular profile, evaluate the tolerance of the treatment, and the ECOG performance status of the patient. So in a non-BRAF patient, after progression of FOLFOX or FOLFIRI, patients with all RAS tumor types, so KRAS, NRAS, and BRAF wild type, who have not received anti-EGFR therapy before should receive combined treatment with irinotecan and anti-EGFR therapy. And then patients with KRAS and NRAS mutant tumor types are considered to have refractory disease following second-line treatment. So in that case, bevacizumab, once again, is commonly continued into the second-line therapy for patients that have a RAS mutant tumor type. Following second-line therapy, 3 drugs are currently approved in the third-line setting, which is regorafenib, which is a multi-targeted TKI. Trifluridine and tipiracil or TAS-102 plus bevacizumab is also approved in the third-line setting. And fruquintinib, which was an oral VEGF inhibitor, VEGF receptors 1, 2, and 3, is also currently approved in the United States for the refractory setting. So once again, these are kind of very different scenarios. So if you're BRAF V600E and seeking second line, you would do encorafenib and cetuximab. If you are a patient that had prior VEGF therapy that's not BRAF, you would continue on bevacizumab into the second line setting. And then once again, if you're RAS wild type, you would receive anti-EGFR therapy commonly in the third line setting if you've not received it in the first line setting. I know it's a little bit confusing, but there is a sequence to the therapies.
Thank you so much, Dr. Eng. As you mentioned, yes, it's very in-depth and very much going in the direction of personalized medicine when you incorporate the molecular targets for our patients. It's a very highly specialized field, and I look forward to the advancements in the near future. Now, I wanted to go into the topic of incorporating surgical intervention, if at all possible, for our patients. So, Dr. Smith, would you be able to comment on how we would incorporate surgery?
Sure. Thanks, Janet. And thanks, Dr. D'Angelica and Dr. Eng, and looking forward to hearing from Dr. Sanford as well here shortly. But, in the first line, we typically think of a surgery first approach very rarely, especially when the primary tumor is either a rectal tumor like it is in this case, or the colon primary is otherwise asymptomatic. And we think of metastatic colorectal cancer as resectable when the primary tumor and then all metastatic lesions are amenable to safe removal. But we must keep in mind the technical aspect of achieving an R0 resection and the patient's ability to undergo surgery, their performance status, and then, of course, the extent of disease. And then careful consideration of the molecular profile, tumor biology. And then, as Dr. Eng mentioned early on, it's really critical to have a multidisciplinary discussion about these patients so that we are selecting the optimal treatment approach and also the sequence of therapies. As you can tell, it's critical, and really need all the experts in the room to decide what's the next best step. Now, in those cases of unresectable metastatic colorectal cancer, systemic chemotherapy is the preferred first line, as has just been very nicely discussed, and current data does not support resection of the primary tumor. To further emphasize this, a surgery first approach in these cases can be pursued, but This is typically in patients with either obstruction, significant bleeding from the tumor, or impending perforation. All of these are scenarios which would prevent an opportunity for the patient to safely undergo sustained systemic chemotherapy. So this brings me to Dr. D'Angelica. Can you give us some of your historical perspective for the management of colorectal liver metastasis, where we started, kind of where we are, and then your views on workup, management, resectability, and even thoughts on sequencing of treatment?
Yeah, absolutely. Thanks, Josh. It is fascinating to hear that beautiful discussion of all the systemic options that are available that Dr. Eng just went through so comprehensively and really beautifully. But it's very interesting when patients have limited liver metastases that, let's just say, 2 or 3 lesions that are technically resectable. The potentially curative treatment is surgery to remove them. There are some recent data that if they're small and in the proper location and in a well-selected patient, percutaneous ablation can be used. But the historical data shows that resection of liver metastases, when they're limited, and this is a small subset of patients, is potentially curative, somewhere on the range of 20 to 33%, depending on how you select your patients. So surgery is really something to discuss. The workup has to be detailed. I think it's really important that we just don't say, get a standard CAT scan. If we think there's limited and resectable liver metastases, a standard CAT scan's probably not adequate. We need liver-directed imaging, which includes high-quality liver-specific CAT scans. And nowadays, we use a lot of EOVIST-enhanced MRI, which can find very small lesions that are often not seen on CAT scan. And that really helps to sort of work up the patient, get a sense of whether they have extrahepatic disease, because the resection becomes less relevant when there's extrahepatic metastatic disease, and also helps us assess the extent of the tumor burden in the liver and whether surgery is even feasible or something to be considered. And so, the imaging is very, very important. The imaging should include a complete assessment of the primary tumor as well. As Dr. Smith was talking about, rectal cancer becomes very different from colon cancer. I think, we were saying that systemic chemotherapy is the backbone of the treatment, which it is for the great majority of patients with metastatic colon cancer. However, when there's limited liver metastases and it's a colon cancer primary tumor and shrinking the tumors is not really necessary, surgery should be discussed and even considered up front. The difficult thing, and I'd love to hear Dr. Eng's thoughts on this, is that in that situation with colon cancer and limited liver metastases that are resectable, the systemic chemotherapy in multiple randomized trials has not been found to change overall survival in any meaningful way. It may delay recurrence-free survival or improve it slightly, but the overall survival is the same. So surgery is a really big part of the discussion for limited colorectal metastases. And again, I want to stress that this is a relatively small subgroup of the overall situation. Dr. Eng was discussing systemic therapies, which applies to the great majority of patients. And even though a lot of the recurrence patterns or the metastasis patterns are in the liver, really the majority of those patients, or at least a significant proportion of them, have extrahepatic metastatic disease or unresectable disease. And when, the discussion I'm having about surgery is not relevant to them. In terms of sequencing, if you're going to give chemotherapy, it should be short for colon cancer and then go to surgery. The longer the systemic chemotherapy is given, the higher the risk of complications for liver surgery, because the systemic therapies, at least the cytotoxic chemotherapy, can be toxic to the liver, can cause fatty liver, can cause sinusoidal obstruction syndrome, which can cause a relative portal hypertension. And in randomized trials, preoperative chemotherapy was associated with a slightly higher risk of postoperative morbidity for liver surgery. Rectal cancer, as others can talk about in more detail, is a very different situation because, as we all know, we don't always have to operate on the rectal tumor if they have a great response to systemic therapy. So a lot of the initial upfront treatment when there's a rectal primary in place has to do with the optimal treatment for the rectal tumor. So my first question is often to the colorectal surgeon and the medical oncologist, before I consider surgery on the liver, what do you need to do to optimize management of the primary tumor? Now, for unresectable liver metastases, there are a few other very important considerations in addition to all the systemic options that Dr. Eng just went through. One would be transarterial radioembolization. However, in most cases, that is not been shown to improve overall survival, although it can help control liver disease in certain refractory situations. The other thing that we do a lot of is hepatic artery infusional chemotherapy. The drug we use is floxuridine. which is infused through a surgically implanted pump into a branch of the hepatic artery and gives basically very high dose chemotherapy that's completely extracted by the liver. So you can give high dose chemotherapy. In the first line setting, this is associated with a response rate as high as 90%. In the second line setting, somewhere between 50 to 75%. And even in the refractory setting, probably response rates in the order of 30%. Patients can live a very long time, although I should stress that the majority of the data that comes from is from a single institution, my own in New York City, Memorial Sloan Kettering, and in highly selected patients. So whether that will be expanded to the rest of the population is really to be determined, and those hepatic artery pump chemotherapy programs are expanding across the country and internationally. Pump chemotherapy can also downstage patients such that they can become resectable with curative intent, which is a very important outcome, I believe. However, pump chemotherapy should be managed in the context of the known toxicity of biliary sclerosis, which happens in approximately 5% of patients and can be a very significant complication. So I think hepatic artery chemotherapy is something very much to be considered in these patients in the context of multidisciplinary care with a medical oncologist and colorectal surgeon.
Thank you for that. And then Dr. D'Angelica, how do you best determine resectability for colorectal liver metastases?
Yeah, a very important question, but a somewhat loaded question. I think most of us in this field kind of think of it two ways. There's technical resectability and sort of biologic resectability. Technical resectability is based really on the technical aspects of liver surgery. And that really is based less on what you remove, but what you leave behind. So as long as you can remove all the tumors and leave a sufficient liver remnant that can regenerate safely, then you're technically resectable. However, there are certain situations where you are technically resectable, but your recurrence rates are so high that someone might consider them biologically unresectable. If there's, when you start getting to the number of tumors where there's 7, 8, 9, or 10 tumors, surgery can be a helpful treatment. However, the recurrence rates are very, very high. So resectability starts to come into question as the number of tumors goes up to very high numbers. Even simple things like your CEA level, very high CEA levels are associated with very high recurrence rates, and some may consider those biologically unresectable. You can use things like the clinical risk score and various scoring systems that combine different biologic criteria. And so we really kind of stratify them into potentially curative and non-potentially curative. In the patients with, say, less than 4 metastases, no extrahepatic disease, low CEA levels, and a resectable primary tumor, that's a potentially curative operation and completely indicated. But as you get to the very high-risk patients, it's used selectively with different objectives for management of their disease in the long term.
There is a trial looking at liver-directed therapy. Is that correct? And then my second thought, Mike, is can you just give us an update on where you think we are with use of transplant in patients who may have bilobar and innumerable lesions? Any thoughts on how those patients should best be approached?
Sure, I'm happy to talk about that. It's very interesting after, the use of hepatic artery infusional chemotherapy at really one institution for many years. There is now a really growing interest in this across the country and across the world. And we've now developed an hepatic artery infusion consortium. There's probably over 100 centers now doing it. And one of the most important things that consortium has done is to develop cooperative group multi-institutional trials. And one of them is EA 2222, looking at persistently unresectable disease after receiving first-line chemotherapy for 3 to 6 months and being randomized to pump chemotherapy versus standard of care systemic chemotherapy. We're currently accruing to that trial, and we're currently developing other trials in the adjuvant setting, which we haven't discussed very much, or even novel indications. So I think there are ongoing trials, which is very exciting because all the previous trials were really done at Memorial Sloan Kettering, and it's very important that these trials get done in the context of multi-institutional real-world treatment paradigms. Transplant is actually a very interesting topic on this. The story is somewhat long, but I'll try to summarize it quickly. Transplant for this disease was tried many years ago, probably in the 1980s and 90s, and did really terribly, probably due to poor imaging and poor selection. And in an interesting turn of events over the course of the last 20 years in Norway, a number of single-arm trials were done in highly selected patients with, very prolonged stability of disease with liver-only metastases and showed feasibility and really promising long-term outcomes. When that data was presented and published extensively, a lot of us felt that a lot of the outcomes might have been all based on selection. However, a recent trial from Europe, based mostly out of France, called the TransMet trial, compared transplant to systemic therapies in the context of stable disease. Most patients had stable disease for at least a year, and liver-only metastases showed a very significant survival benefit to transplant. Now, obviously, transplant is a huge issue with multiple issues that come along with it, like can you get a liver for your patient? Does it have to be a living donor? It obviously has to be a very young and healthy patient who is stable on chemotherapy for a long period of time. They often require that the primary tumor has been removed, and there are other selection criteria as well. But in highly selected patients, liver transplant is probably going to play a role in the management of liver-confined unresectable metastases. It is interesting that while these patients live longer, the great majority of them will recur after transplantation. However, the majority of them are small numbers of metastases in the lung, which can often be managed with ablation or surgery, and these patients can live many, many years. So it's a fascinating turn of events and a testament to a really bold trial done in Europe that showed a survival benefit to transplant. And we do refer patients for this when they fit the right criteria, which is a small group of patients, but when you see them, you should really consider it.
Yeah, that's super helpful. Thanks so much. Just one quick, tangential point to what Dr. D'Angelica was saying is typically if somebody is going for transplant, we would resect the primary tumor prior to transplantation.
Thank you so much for that interesting discussion. Dr. Smith, what factors play a role in determining the resectability for the primary tumor?
Sure, I'm happy to get into that. So resectability for tumors in the colon is rarely an issue, typically a cecal tumor or a sigmoid or a left-sided tumor. But we do manage some patients with clinical T4 tumors, those invading or encroaching on other organs like the bladder, stomach, or pancreas carefully. And these require a very multidisciplinary approach with surgical planning and then potentially achieving downsizing and appropriate tumor response so that we can ensure a margin negative resection. And we very often coordinate for a staged approach or a synchronous approach with our HPB colleagues. And that's assuming there are other potential options for the liver or the lung, should there be disease outside of the liver, for example. Now, rectal cancer, for example, in this case is a completely different scenario, and features such as lateral pelvic sidewall, distal tumors, also T4 disease involving other organs or EMVI, and a high degree of nodal burden factor into the selection of how we best gain local control. And we want to optimize the management of the disease sites as it relates to the metastatic disease. This is really critical for any chance to achieve a potential cure. And we certainly work closely in a multidisciplinary fashion with our radiation oncology colleagues, medical oncology colleagues, and HPB and even thoracic colleagues to select the modality that gives us the best chance for local control of the primary tumor and then address the metastatic disease. And certainly we're careful to introduce local control options at the appropriate time. And this is a good segue for Dr. Sanford to tell us where we think that either a short course radiation approach or a long course chemoradiation approach is appropriate to obtain an optimal response to the primary tumor.
As you said, Dr. Smith, we're lucky to have an expert in radiation oncology like Dr. Sanford here. So, in this case of a low rectal tumor with metastatic disease, what are your thoughts on the use of short course versus long course radiotherapy and how that fits in sequencing wise with systemic chemo in this patient with metastatic disease in the liver?
Yeah. So first of all, thank you so much for including me in the discussion. I've already learned so much from the other speakers here. Yeah. So just to give some background, I think the listeners are aware, but short course is 5 gray times 5 fractions daily. So that's done in a week. Long course is 1.8 to 2 gray over 5 to 6 weeks to about 50 to 54 gray total. And for me, I think the decision between the two in the metastatic setting really depends on 3 things. The first is the burden of disease elsewhere outside of the pelvis. Obviously, we would assume that the patient is responding, that their disease is not progressing for considering consolidated local therapy, but the exact burden or extent will probably influence how comfortable you are giving them a break off of multi-agent systemic therapy and how long you want to take for radiation. The second would be the extent of residual disease in the primary tumor, particularly how well it's responded to systemic therapy and all those risk factors that Dr. Smith talked about that would predispose a patient to have a positive margin if those are still present after chemotherapy. And then the third that has become increasingly important, I think, in 2026 is whether or not the intent of the radiation is pre-op or definitive intent. So generally for pre-op radiation, if there are no high-risk features for local recurrence, we generally preferred short-course radiation to get it done quickly, maximize time off of chemotherapy, especially if there are untreated sites still present. However, if there are those risk factors for positive margin T4, contacting nasal rectal fascia, obturator nodes, etc., then we may need a longer course of treatment. And in these situations, we try to address the rectum last. Now, the final thing I'll talk about is that there, as I'm sure everyone's aware, there's been growing interest in organ preservation for all stages of rectal cancer, but perhaps especially for stage 4, especially in these cases, a distal tumor. It makes sense because since these patients unfortunately have a higher risk of distant recurrence, even if we've addressed all sites, the idea of having a permanent colostomy only to potentially later develop metastatic lesions elsewhere is understandably less appealing. So, the data are not as established as in locally advanced rectal cancers like the Oprah trial and whatnot, but I think, a lot of us are comfortable extrapolating from some of those studies. And if that being said, if the treatment intent is definitive chemoradiation for stage 4 tumors, then we would recommend long course radiosensitizing chemotherapy to get to a higher total dose.
All right, well, let's make it even more difficult. Let's say in addition to her liver lesions, she's also found to have lung lesions consistent with metastasis. What would be the role of radiation therapy in this scenario? And would you consider using SBRT?
Yes, I would. So yeah, we start with systemic therapy to understand the biology of the disease, see how it responds. If they have good response or at least stable disease and nothing new, start thinking about these local treatments. I think with respect to LUTMET specifically, we do often recommend consolidated SBRT. I like how Dr. D'Angelica framed the decision with regards to the liver, kind of dividing into biology versus technical feasibility. And it's really the same for me for SBRT. With that, I generally, don't treat maybe more than 5 lung mets. If, patients really have more, then it probably reflects more disseminated disease, even if occult and, other markers like was previously mentioned would be a high CA. But for us, also a practical issue, because if you are treating several tumors kind of scattered throughout the lung, then you are exposing more normal lung to irradiation. Of course, depending on where they're located, how spread out they are, the size of them. So I kind of look at the big picture with regards to disease trajectory and the location of the tumors, how many. It's really not a hard cutoff, but kind of go on a case-by-case basis. But presuming that we do offer radiation, it's delivered in anywhere between 1 to 5 fractions. I try to do more and more single fraction when able. And it's generally really low toxicity, so we often are able to slip it in sort of between systemic cycles or other treatments, wherever the patient has a gap. Maybe at this point, I'll just sort of segue back up a step and sort of generally talk about the role of SBRT in metastatic or oligometastatic colorectal cancer. Obviously, this is a big topic, but I think I just wanted to emphasize a few points. The first is sort of defining what oligometastatic is. And I think has already been alluded here. It's really more a concept than a formal binary definition. And the idea is really to identify patients with metastatic disease burden who are less likely to harbor disseminated occult tumor burden, so-called, like what we see on the scans is the tip of the iceberg, because we think that in these patients, aggressive local therapy might have the potential to alter disease trajectory, provide long-term tumor control, and even cure in some. In 2026, I don't think we are perfectly able to identify who this patient population is, but some surrogates, we talked about number of tumors, number of organs, and which, if a patient has disease in the peritoneum, we think of that as more disseminated. When the metastatic tumors appeared at diagnosis or after a long interval stability, sort of the overall disease trajectory. So it's really a number of factors that we try to take into account to say if this patient is oligometastatic or not. The second point I also alluded to above is that SBRT is generally convenient and low toxicity in really the majority of patients. It doesn't mean the risk is zero, but most patients report really few side effects. I would say, especially the lung tends to be very well tolerated and very low side effects. So when we think about sequencing, I think two things come to mind. The first is that we can try to slip it in between other treatments. And then two, I think when we think about integrating with potentially more invasive local therapies, such as surgery to the primary, we might do radiation first because it's potentially less toxic, to give sort of more a test of time before committing to a surgical procedure. And then the last point, which will segue into our next discussion, is, we want to know what is the data for SBRT in oligometastatic colorectal cancer. And I think we're getting there. I'll admit that most of what we have right now is sort of like these single-arm studies that are very promising, but I know, we all know that the major limitation here is selection bias. There was a phase 2 randomized trial, the Sabre-Comet study, showing better overall survival in metastatic cancer with the addition of SBRT, but this was across several disease sites, and I think there were about 18 to 20 colorectal cancer patients, so the subset is quite small. There are a lot of challenges to accruing to these studies, which I won't get into, but as will now be described, we do have an ongoing phase 3 randomized trial, which we're all really excited about.
Comprehensive local radiotherapy is being prospectively evaluated in the Evaluating Radiation, Ablation, and Surgery, the ERASER trial at Ohio State led by Dr. Eric Miller. This ongoing phase 3 study examines whether the addition of total ablative therapy, or TAT, defined as the eradication of all metastatic sites through a combination of stereotactic ablative body radiotherapy, surgical resection, or thermal ablation in conjunction with standard systemic therapy, improves survival in patients with limited metastatic colorectal cancer. Eligible patients with up to 4 sites of metastatic disease are randomized to receive systemic therapy alone or systemic therapy plus TAT, with overall survival as the primary endpoint. The trial reflects a growing paradigm in which aggressive local therapy is applied to all sites of metastatic disease in an effort to delay progression, prolong survival, and potentially achieve long-term disease control in selected patients with oligometastatic colorectal cancer.
Finally, I think it's important to note that palliative interventions remain a critical component of care for patients with metastatic colorectal cancer, particularly for those that have highly symptomatic disease and metastases not amenable to curative intent therapy. Systemic chemotherapy remains the cornerstone treatment in this setting and is typically administered with palliative intent to prolong survival, control tumor burden, and alleviate symptoms. In addition, regional radiation therapy can provide effective palliation of pelvic pain, bleeding, or mass effect from locally advanced rectal tumors. It can also control symptomatic lesions, such as painful bone metastases or spinal cord compression. Endoscopic approaches are also intriguing, including those such as self-expanding metal stent placement that may relieve malignant large bowel obstructions and help to avoid emergent surgery in selected patients, while diverting ostomy or limited surgical procedures may be required for refractory obstruction, perforation, or fistula. Image-guided interventions such as percutaneous ablation and embolization have also begun to play a role in cases of bulky symptomatic disease. Together, these strategies underscore the importance of multidisciplinary palliative management focused on symptom relief and maintenance of quality of life, while systemic therapy addresses overall disease burden.
Thanks, Phil. This has been a really excellent in-depth discussion of the multidisciplinary approach to metastatic colorectal cancer. In summary, our main takeaways from today's conversation: metastatic colorectal cancer has a poor prognosis. However, a select group of patients can achieve cure with a combination of systemic therapy and surgical resection. Modern day treatment is driven by precision medicine, as Dr. Eng so kindly went into a very detailed discussion about first line as well as second and third line treatment. This is based on molecular profile and does predict a patient's prognosis as well as treatment response. Surgery and liver-directed therapies can significantly improve outcomes, and there is an expanding role for radiation, as Dr. D'Angelica and Dr. Sanford also described for us. Overall, the management of metastatic colorectal cancer requires a multidisciplinary approach, integrating systemic therapy, surgery, radiation therapy, and consideration of palliative care to optimize survival and quality of life. Thank you so much, everyone, for joining us today. I hope that you have learned the overall management of metastatic colorectal cancer, and we appreciate you tuning in. Thank you.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.